And we're excited about this panel because obviously behavioral health is an important topic, and it's a great opportunity to understand what is happening in other states. So let me go ahead and kick this off. Our moderator today is Dr. Luke Bergman. Dr. Bergman is currently the Director of Integrated Services for the County of San Diego Health and Human Services Agency, and will, more importantly from my standpoint, be transitioning to the role of Director of Behavioral Health Services as of March of next year. He most recently came to us in San Diego from New York City, where he was Assistant Vice President over Behavioral Health at NYC Health and Hospitals, the nation's largest public hospital system. The other largely unknown fact that I told Luke I was going to bring up is he's also an author. So with that, Luke, if you'd come up, please.
It's my great pleasure to be here. As Demetrius mentioned, I am sort of actually now transitioned out of my role as Director of Integrative Services and am in the role of Director of Behavioral Health Services here, kind of job sharing with Alfredo Aguirre, who is, I'm sure, familiar to many of you. So we are sort of job sharing for the next few months as that transition is completed. And as Demetrius mentioned, I was also quite recently at New York City Health and Hospitals as AVP or Behavioral Health. Before that, I was at the Department of Health and Mental Hygiene for New York City, where I had an opportunity to participate actively in the development of an 1115 waiver that most significantly resulted in the carving in behavioral health services to the general managed Medicaid plan in New York State. So in conversation with Demetrios about that body of work and my past, he thought it would be useful for me to participate in this conversation. I am very pleased to be participating as a moderator. We have three esteemed folks who have come from areas far and wide, including New York, Tennessee, and someone closer to home, Arizona, to talk about their efforts to achieve better integrated behavioral health and physical health care through various models of carve-in. It has already been mentioned that the payment models here in California and in San Diego County specifically are very fractured. I think, do we all agree that they aren't ideal right now? Can I get a what if there's agreement that they are not ideal? Great. I didn't hear what, but I heard, I think, consent to that idea. So I won't sort of belabor what is the current state. I think we all sort of understand that the current state is very fractured, that there is a lot of emphasis on who owns what person for what period of time, and that sensibility is probably not ideal for best either immediate or long-term outcomes for the patients we all have an interest in caring for. So we are going to hear today about past experiences that I think should significantly enlighten us about what best roads forward may be for us. I know you are all interested in figuring out what we can do next. It's wonderful to hear about how great life could be if we did something radically different. I think what we want to try to glean from the current conversation is like, okay, what really mechanically can we do to begin to drive this forward? And so I think we're going to be hearing some of that in the panel upcoming. So I'm going to begin by introducing the three people on the screen who are all much better looking than I am, and inviting them up. The sort of run a show here will be that each will give 15, maybe 16 or 17 minute presentation on their experience doing this work in their jurisdiction. And then we will have Q&A. I have some cues prepared that they can but we really want this to be as conversational as possible. I think it will be most useful if it is most conversational, so please don't be shy. You can certainly interrupt my questions to supersede them with your own if you feel if you feel like they're better. So let me begin by introducing Dr. Steve Chemukhin, whose quite amazing bio is in your brochure, so I won't repeat the whole thing, but he's CMO at United Healthcare, community plan in Arizona. Dr. Chemukhin. And Mr. Steve Gaither is Director of Managed Care for TennCare from Tennessee. Please come up. Keith has the most melodious Tennessee accent, so you are all in for a huge treat. It's probably a better sleep aid than my book, even. And then finally, Dr. Andrew Kleek, who is at the McSilver Institute, where he is Chief Program Officer. Andy is what I call him. I know him well from the time I spent in New York City, has been very involved in the Carvin work in New York. So please welcome Andy as well. Okay, now I'm going to move from here down there, so just like watch this. How is that? How is that? And invite the first of our presenters to give his spiel. And then after all three spiels are given, we will commence the Q&A. Thank you so much.
Thank you, Luke. And thank you for the invitation of being here today. Really appreciate it. This was sort of the overview slide that Luke had given us some information on. And so at the bottom, so the top's, sort of the issue that was raised, and then, how has our state, anyway, Arizona's Medicaid system, progressed into our behavioral health carve-in? And then at the bottom, sort of these are the objectives that we tried to, we're intending to get through and some of the information being presented today. So hopefully I will accomplish that with you. There's a fair amount of information on the slide. However, really what I wanted to focus on here is that, Arizona entered the Medicaid space later, 10 years later, than any other state in the country. And, I think to that end, when they did enter, they had the opportunity, Arizona as a state had the opportunity to learn from other states that had preceded it. And for better or for worse, and I think better, they decided to go straight in with all managed care at the time when they started to introduce their main acute access benefit in around 1982. For the next 6 years or so, it really was just that Medicaid benefit provided without behavioral health services for the most part by, anywhere from half a dozen plans depending upon the geographic service area of the state. And then in 1988, 89, the next product that was introduced was long-term care, EPD, elderly physically disabled product. And at the time, and looking back, that was momentous. They went straight from that benefit to one that was for a very complex population and included not only physical, but decided to do a behavioral health full carve-in as well as HCBS services. And that health plan and that model has been very successful in the state. One statistic that I don't have in here is that I think initially that group of members that qualify, about 74, 73% of those individuals were at the time residing in skilled nursing facilities as residential placements as needs. Today in Arizona, that statistic is hovering around 22, 23%. So with the behavioral health carve-in, with the wraparound services, and with the work that our teams do with a one-on-one case management ratio of about 1 to 60, we've been able to make a substantial difference, I think, in the population that we've served over the years. Then in the 90s, as a behavioral health benefit actually materialized, first with adults and then with children, the state actually introduced it as a carve-out. So the carve-out was to what are called in Arizona as regional behavioral health authorities, or REBAs for short. And how that happened and the details of it aren't that important, except for to say that we had an integrated plan followed by a disintegrated plan, and since that time, it's taken us until pretty much October 1st of this year to reintegrate the behavioral health services in the state. So this is a bit of a pictorial of that change over time. So you'll see the inception of the program in 1982, followed by that EPD, long-term care plan, with the membership figures there attached to that. And you can see there was a gap of about 25 years roughly before the state had itself aligned and started to make the policy changes and had the plan in action to start reintegrating care and services. That CRS health plan program there is small. It's a specialized program that was once run by the state. It was put out to bid, and United Healthcare Community Plan actually was awarded that in around 2005, and we managed it until this most recent change on 10/1 of 18. That was a big deal for the state because it was Access's first foray, Access being the Arizona Healthcare Cost Containment System, the Medicaid division in Arizona. It was one health plan that they had complete authority over, so they were able to, with that authority, say, we're going to go ahead and change that health plan from one that provided just a segment of individuals' physical care only, and these were individuals that were also had commercial plans. They had getting services from other Medicaid plans, as well as behavioral health services from those REBAs I mentioned. So it was a very, very disintegrated system. They, in one fall swoop, put it out to RFP and said, you're going to go ahead and take care of all the behavioral health and all the physical services and the specialty services for those members. And it's been working pretty well. Those members were reintegrated into our Access Complete Care plan as of 10/1, and I'll get to that. But I'll also show you a little bit of statistics and a little bit of improvement we saw during the 5 years or so of integration that we did have with those members. So then in bite-sized pieces, they went to the adult population that have serious mental illness next. And they said, we're going to try it first in our largest county, Maricopa County, which is where Phoenix, Arizona is at. It's where I'm based out of. Trying to take the adults who have that serious mental illness who have physical health care needs, and instead of bringing those members over to the acute managed care plans, they said, let's move those members over into those REBAs that have been providing all the behavioral health services, since that's the main types of services those individuals seem to consume and need. And let's ask those REBAs to start providing their physical health services. So that was a huge change in the state, and it went off quite well after it got started, so much so that they decided to proceed with what was called Greater Arizona, which was that blue box next. That's when they went to the southern counties and the northern counties and decided to do the same thing with the rest of that adult population with serious mental illness. And then in 2016, as you can see, this is accelerating now in the last 5 years, they took patients with original or traditional Medicare who were with our health plan, who had been getting their behavioral health services from those REBAs, and said, we can impact that. So they moved those individuals over to the acute managed care plans, like the one I'm the chief medical officer of, to provide their behavioral health services. And then finally, it brings us up to 2018, which was just 6 weeks ago, which was by far and away the most massive change in the healthcare system in Arizona Medicaid since its inception, at which point in time they took pretty much the rest of the children and adults who received general mental health and substance abuse services and moved those behavioral services from the REBA over to the acute managed care plans. So that is the story of about how we've gotten to this point in Arizona, where in effect now you have these complete care, managed care organizations called integrated contractors, which United Healthcare is one of those in Arizona, providing physical and behavioral health services for individuals that except for those with adults with serious mental illness. You've got the REBAs that are providing integrated physical and behavioral health services for adults with serious mental illness. And then you have our long-term care EPD plan that I mentioned early on, which has been integrated since 1988 or 89. The one part, or a couple parts left, is that there is a separate division serving individuals with developmental disabilities who today still remain in one of the most fragmented healthcare delivery models that we have in Arizona. Many of them have commercial insurance. They obviously have significant intellectual disabilities that we help care for. However, their services are split between our health plan, where we provide their acute services. Their behavioral health services are still provided by those REBAs. And then the division itself, run by the state, provides their HCBS services. So that is a very vulnerable population that still needs to go through an integration process, and that is actually out to bid right now in Arizona. and it should go live on 10/1 of 19 when they launch that. Got to have a pretty picture. So the left is really just intended to say, you know, before we had health plans over here, we had these REBAs over here, as well as the separation with because the Department of Health Services used to be a separate division. And with this change, Access actually moved the state agency, the Department of Behavioral Health Services, under its purview, under its control. And then with that, really aligned those systems so that hopefully a member, for the most part, will have, you know, one provider, one health plan, and receive all of their behavioral health and physical services through that one health plan. So Luke wanted us to talk a little bit about how the state managed to get there. I mean, I just went through a lot of change in a relatively, you know, short period of time, but clearly it didn't happen overnight. However, it did really accelerate in the last 5 years in the state. And, you know, one thing I think that the state did very, very well was they developed really alignment across the agencies. They developed a very clear strategic plan that was going to integrate the care and delivery services for the individuals that we're privileged to serve. And in that, sought lots of stakeholder engagement, and that included hospitals, outpatient treatment centers, PCP specialists, and used all that information to help form their decisions. And then over time, they released what they call major decisions, which were releases that in effect said, we've gotten all this information in, now this is the strategic direction we're gonna head in. And they stuck to those strategic decisions quite well over the last 5 years. They were very good, the state and the health plans together, working together, were very good at proactive and recurrent, repetitive communication. And then despite that, even through all these changes after each one, there are still a number of our members and our providers who still weren't aware that those changes were going to come. So I think that over-communication and the way that it was done was very helpful in the overall process. And then last, the state, working together closely with the health plans, have a very rigorous and very disciplined process for how we prepare. We prepare for these transitions well 9 to 12 months in advance. There are very specific files with shared data formats that are defined between the health plans and the state in a partnership, exchanging a great deal of information around individuals that we're receiving or who we're transitioning out of our health plan to other health plans, such that what we achieve is what Access refers to as really a seamless change in health plan for individuals, and that we don't drop the ball. That's particularly true around high-risk needs, so people undergoing chemotherapy, people who have had transplant, people on dialysis. And I will say that with practice, we keep getting better and better at this, but this most recent transition of it was 1.5 million or so recipients, hundreds of thousands of members literally changed health plans across the state. It went remarkably well. It has been overall quiet. It's gone very, very well. There's still some bumps in the road that we'll need to work on, but it's actually gone quite well for that preparation. And the other thing that's important I wanted to highlight is I wouldn't profess to know how the crisis system works precisely in California by county, but in Arizona, it's developed over quite some time. And one thing the state wanted to do was to try not to disrupt the crisis delivery system through all of this change, recognizing the critical importance that it serves, the experience of the providers and the groups that provide that service, and then how much the hospitals, frankly, rely on a very clear and precise crisis delivery model. In Arizona, there are mobile crisis teams that go out throughout the state. Those mobile crisis teams help very, very much with diversion from hospital emergency departments and or inpatient events to lower or alternative settings. If someone is in the hospital, let's take the ER for a moment, there's daily communication between the crisis system and every hospital in the state to understand who's in the ER and for what reason and for how long. And that is communicated very clearly to us as health plans and payers so that we can actually get involved coordinate from a care perspective and a placement perspective. And then if someone is admitted, then the crisis teams actually go physically, as do we actually, go physically into the hospitals where we're permitted, meeting bedside with patients, talking specifically with the doctors and the people that are involved in the care to try to help reduce the length of stay, help identify an appropriate alternative placement, and work collaboratively to achieve that. So the crisis system in Arizona was largely left untouched. The way it works now, since the first of the year, or the 1st of October, is that the first 24 hours of crisis services reside with the REBA's responsibility, regardless of where that member lies in the system. And then after the first 24 hours, if the member is ours or with one of those integrated contractors, we assume responsibility, step in, and coordinate from that point forward. So a couple other things that I think have been done very, very well is we have introduced a provider advisory council. I didn't change the slide, sorry. We've introduced a provider advisory council that consists of hospital partners as well as physical and behavioral health partners to help inform us and have really open dialogue around what needs to be fixed and where we can improve, where we're falling down, and they also tell us where we're doing really, really well. That helps very much in the collaboration we have toward improving care and working together. There are some specialized programs I think in Arizona are very helpful and help empower care delivery more so at the practice and provider level. For example, we provide care management and care coordination services, but behavioral health providers actually provide case management, and they're able to bill us for those services. And so where we need to step in and provide a care coordination or a care management support, we do. But where they can actually drive case management activities and working directly with their patients, they can. And that helps, again, it helps us step back and allow care to occur where we believe it can occur best directly with the provider, but we're still there to step in when there are certain unique programs. One of those on the slide is Justice Reach-In. About 3-4 years ago, we started working with the state, and I think some other states have done this before us, around Justice Reach-In, where we can actually work with recipients that are coming out of the justice and prison system, try to help meet with them before they come out of the justice system, find out what their needs are, and help meet those needs even before they come out, helping to avoid what oftentimes turns out to be emergency department visits or hospitalizations. We do a great deal of data sharing as well. Really quickly, here's a couple of the results that we've experienced. So high risk, high needs is a collaboration between us and the regional behavioral authorities. That was before the integration. These were members that we jointly picked to work on together and care manage. These were some of the results that we experienced in working together with very high risk needs individuals. PMPM reductions by 67%, ER down 51%, and inpatient admissions down 62%. And that is on a reasonable population of over 250 to 300 members a year that are managed through that process. I mentioned quickly that our CRS plan was fully integrated for 17,000 members. I did want to note that over that period of time, patient satisfaction scores went up in this very, very complex, high-risk group of individuals. And our utilization trend for both inpatient and emergency room department visits declined over that period of integration. So lastly, I think I touched on most of the key points, but engagement's been key. Early and solid planning on this, keeping the crisis system strong in the state, working to expand alternative levels of care so we can help with placement, so there isn't a lack of placement opportunities. Carefully considering key delivery system issues, transportation being a big one in our state, and getting ahead of that and having a lot of pre-planning around that. We've been working heavily on incentives and aligning incentives to try to help align the right type of care in the right locations. And it's been talked a lot today, maybe we'll talk about it afterwards, but we've had a lot of focus on social determinants of health and a significant focus on housing and how we address housing and food insecurity for the patients we serve. So thank you.
Thank you so much, Steve. That's great. Now we want to invite Keith to the microphone.
To the microphone. I don't have any slides, so I'm just going to sit here. TennCare, which is Tennessee's managed Medicaid program, started in 1994. In the first 10 years of that, we had MCOs and BHOs, so behavioral health managed all of, the BHO managed all the behavioral health needs of all of our members, and MCOs handled everything else. In that first 10-year period, we had a rocky start. We didn't really know what we were doing, to be honest, but we got better over time, but we restructured everything in 2004. And as part of that, we decided to integrate at that time, get rid of the BHOs. Two main reasons for that. One was we always had trouble defining whether a BHO or an MCO should pay for certain services, which is really kind of ridiculous. So to give you a very simple example, we had a woman who went to a hospital with some pretty serious medical issues because of an eating disorder. So we had our MCO and BHO arguing about who should pay for that hospital stay. So you can imagine what the aftercare management looked like on that. Also, those two entities did not coordinate care management very well at all. They may have tried, but it's just very hard to do with two different companies doing that. So we decided to lump it all together. You will, if you look at my bio, see that I and my team got an award from the Mental Health Association in Tennessee. I think I got that for two reasons. One is we went out and talked to every community mental health center in the state about what integration was going to look like. And two, I didn't destroy the mental health system in the process, which I think they appreciated. You know, it's kind of evolved over time. I think what has come out of us being integrated, there are two or three very important things that have happened. One, we could start engaging our MCOs in managing the whole person and not doing just your disease management programs that a lot of people were doing back then. You know, you got your diabetes, your COPD. You could start screening someone for all of those issues that they have and manage them as a whole person. The second big one was when the SIM grant money came along, we leveraged that to start health homes for SPMI population. We had in Tennessee terms, a very large spend on case management, which would look very small in California, but we were spending about $100 million on mental health case management. My MCOs were telling me that wasn't really structured well, outcomes were iffy, so we thought, well, let's use this opportunity with the SIM grant money to restructure that case management program at the mental health centers. Two things we did there. We developed a care coordination tool so that our mental health centers who were assigned attributed members based on diagnosis and any interaction they'd had with the system in their area, we attributed members to them. They could get information through that care coordination tool, including ADTs from hospitals and any gaps in care that those members were having. Because, and as probably as you guys know, the SPMI group engages with mental health and nothing else. So that community mental health center is really the key to getting those patients engaged in physical health and how that can be improved. So it solved a riddle for us on what to do with all that case management money we were spending. And it also, we use that money as well to start that care coordination tool, which has been tremendously helpful for us. It also started the path of where we're going to go next, I think, is paying those health homes for reduction in total cost of care, which gets us into more of a value-based payment program of if you can help me save money on the physical, we'll give you some of that money back. So there's no way we could have done that in a bifurcated system that we had. Lessons that we've learned through this, integrated healthcare doesn't happen just because you've integrated your management. It does create opportunities. You got to have that combined payment. The incentives get more aligned that way, but you've got to engage the delivery system and help facilitate those discussions around integrating treatment in different settings. I'm going to leave it at that so we can have more time for questions.
He likes extemporaneous question answering. That's great. Thank you so much, Keith. That's very helpful. This is Dr. Andrew Gleek.
Hi, good morning, everybody. So I have to admit that I am from California originally and grew up out here. And when I get the slides up. When I get off the plane tonight at like 1 o'clock in the morning and it's snowing in New York, which is supposed to be doing, I am going to be seriously questioning my life choices. And you know, Luke has clearly made a very good choice of coming back out here. The right choice of coming back out here. So So I'm going to talk through really the nuts and bolts of this. I'll talk a little bit about why I'm going to do that, just given my background and what I do. I'm going to talk a little bit about really the nuts and bolts of this, give a little context to what was happening in New York State, talk about some of the strategies that I think have made this successful, some of the ongoing challenges, and then hopefully have a little time at the end to talk a little bit about lessons learned, really at this kind of very, very granular nuts and bolts level, which I think is good given the kind of context of the other presentations. Oops, did I hit the wrong button? No, okay. All right, so I'm the Chief Program Officer at the McSilver Institute for Poverty Policy and Research, and there I oversee all of our technical assistance activities. So we have a wide variety of acronyms associated with technical assistance where I work, and the quick answer is we work with every mental health, substance use, child welfare, and intellectual and developmental disabilities agency in the state of New York. That's different than California, but New York is a large state as well. So it's a wide swath. And I think one of the things that you learn in doing that is that, it's a diverse state, both in terms of population, but in terms of rural and suburban and urban, and how all those different pieces fit together. And it's a bunch of different healthcare systems all in one. And so I'm going to try to talk a little bit about that as I walk through today. Okay. If I give this presentation in any other state other than California, these numbers seem huge. In California, you go, yeah, whatever. So, I've done this in other places, and you say $60 billion, and people go, oh, wow, but California is California, so I'm not going to get that here. But wow. There we go. Thank you, Luke. I really appreciate that. You can talk about HHC and how big it is, too, and people have the same response. The key is that a large amount of New York State's budget was being spent on Medicaid, and the growth rate of Medicaid spending was crunching out literally everything else out in the state budget. So it was not sustainable. There's also a tremendous number of people, 6.4 million people are on Medicaid in New York State. So just some context for this carve-in. First of all, there was a financial crisis. So that reduced state spending. Medicaid expenses were going up as people lost their jobs. More people went on Medicaid because New York State has traditionally had a very liberal approach to Medicaid enrollment. And so it was leading to cuts in other areas, and that was unsustainable. The other thing that's not on this slide, which I do want to say, is New York State looked hard at how much they spent on Medicaid. New York is traditionally and will always be a richly funded healthcare system, but looked at their outcomes. New York's outcomes in comparison to what they spend are similar to the United States' outcomes, right? You spend twice as much, and we were always in the middle of the pack at best. And so the question was it really a good use of the investment to really be spending all this money? And so there was never a discussion of cutting funds, of saying we're going to take a lot of money out of the system. The goal was really to reduce the level of growth in the system. And so I think that was the approach in which New York State government went into this. I also want to say, and this is one of the key distinctions between New York and California, while California is largely a county-based Medicaid system, New York is a state-based Medicaid system. The counties play a role in Medicaid in New York State, but they do not play the kind of organizing, controlling role in state Medicaid. It is not administered at a county level. The counties are involved, but New York State really does run the show in terms of the rollout. The other thing, and this is similar to San Diego as well, is there are a number of Medicaid managed care plans in New York State. There are 18 of them. My colleagues and I joke that there's one we're not really sure is a plan. They have a website. I think they have some members, but we're not sure. I won't name that plan. But there are 18 plans in New York State, and there are 10 plans in New York City. So if you're a nonprofit behavioral health agency signing up for managed care contracts, you may be managing 10 contracts at the same time, and that can be obviously, from an administrative perspective, very complicated. So anything that was going to have to happen had to take place in the context of that complexity. In addition to that, New York State engaged in a district project, got a massive waiver from the federal government to the tune of $10 billion. That largely went to the hospital systems in New York. But part of that deal was also that New York would move largely into value-based payment arrangements in the 5 to 7 year period. So now in 2020, it's something like 75 to 80% of all arrangements in New York State are going to have to be value-based. So it's this transition from transition of fully carving in mental health and a variety of other services, and then rapidly transitioning into value-based payments. And so as people are getting caught up with one thing, they're also in the midst of doing this whole other conversation. And that's really important as well. New York was also a early and big adopter of health homes, went into health homes in a very large way, carved in a number of existing care management systems made them health homes. That 90-10 match from the federal government really helped people make those decisions. And so that also happened at a parallel way, but not necessarily a fully integrated way. And I think one of the lessons learned here is that the behavioral health carve-in, the DSRIP project, and health homes all in some ways happen parallel and not fully integrated with one another. And I think one of the things, and as things have not gone successfully, a lesson learned there is to think about those three things in consort rather than separate things. So just to keep that in mind as we talk through today. So New York model, fully integrated carve-in, and I think one of the differences between what New York did and some of the other states that have talked today is it's not as if New York went from having all of individuals' physical health care needs being covered by managed care plans. For people with serious mental illness and other special populations, they were paid fee-for-service from state Medicaid. So it wasn't a carve-out where they were in a behavioral health managed care plan for one thing and they were in a physical health managed care plan for another. They were in a state-funded system for one thing and private managed care for another. So it's going into managed care entirely and also going into a fully integrated plan, and I think that's important to know as well. The goal was to increase the availability of services, particularly ambulatory services, and then reduce per capita costs. And then for the adults with serious mental illness and serious substance use disorders who also have a long history of high spending, so not everybody with a serious mental illness diagnosis and not everyone with a significant substance use disorder diagnosis, but for folks who had both of those things and also a long history of increased spending, they were carved into a special needs plan, which New York called a health and recovery plan, or a HARP. At one point, we had a HARP and a disco, and it was in a health home, and people were getting really, really confused. But so basically, for the folks with the highest needs, they carved them into a SNP, but those SNPs were then operated by the existing managed care plan. So they would have their regular plan, and then they would have a SNP within the HARP plan within the context of that. Does that make sense, everybody? Okay. And this also, just to reiterate, is occurring alongside the DSRIP project and also the movement towards VBP. So people are managing all of these things at the same time. Okay. Just to touch on this, most people who are Medicaid recipients with mental health and substance use disorders are getting carved in. There are still some populations that are going to be carved out, at least for the foreseeable future. The biggest one of these is what we would refer to as duals, folks who have Medicaid and Medicare. They are still carved out and will continue to do so for a while. New York has done some interesting things around some pilot programs called FIDAs, which are starting to provide managed care services for those folks. Those have not grown very rapidly, and so that's the biggest population, which will still be fee-for-service going forward. This started in 2015 and will go through 2020. So basically at this point, almost all adults, with the exception of those who are still carved out, are carved in at this point into managed care. Children are going in this year, slowly over the course of the year. Children in child welfare and foster care are going in, and then the intellectual disabilities community is going to go in after that, likely by 2020, but with all of these things, dates are fluid. New York originally did this like regionally, New York City followed by everything else. As they get closer to doing the children's carve-in, they're just doing it all at once. Some of the regional breakdowns, at the end of the day, it just creates more confusion. And when you had agencies that had services in both, they would have half their services went in on one day and the other half the services would go in a couple of months later. And I think it just got a little confusing for folks. Okay, so this slide just says what I just said. It just got nicer pictures about going in 2015. Okay, a couple strategies And I was joking before this, I was going to get up and after the social determinants conversation, I was going to talk about medical loss ratios. But I think these are some really key strategies that, one, maintain the community of providers, reduced anxiety, and was very helpful. So New York State implemented a medical loss ratio of 89%. So only 11% could go to administration and profit. The other 89% has to go to the provision of services. Also, for 2 years, and it's since been extended, state rates applied across the behavioral health community. So one of the things that behavioral health providers did not have to do was negotiate with the plans on rates. Those rates have stayed stable. There were network provider requirements. So if a provider had at least 5 clients with any individual plan, the plan was required, at least at the beginning, to contract that with them. Going forward, that will likely end, but it provided a stability to the system at the beginning to get everybody in, and I think that was a really important step. The other couple things that I think were really important is the state set up, like at the very beginning, daily meetings on claims questions. So they were looking at access, very closely looking at previous access, looking at current access. They did not want to see a reduction in access, particularly around outpatient services. In addition to that, they were also monitoring all claims issues that came in. There was a lot of effort put into working to make sure that claims were getting processed, people were getting paid. There was real concern about the stability of the financial system for behavioral health providers, and they put a lot of money into that. They also put a lot of money into readiness funds to help particularly smaller providers get ready, purchase an electronic health record system, those kinds of things, and technical assistance, and I'll talk a little bit more about that in a little while. They also set some ground rules for utilization management requirements. There was some areas where the plans had a lot of flexibility, but in terms of that first clinic visit, the first 10 clinic visits, there were pretty clear requirements that you couldn't, deny that kind of base level of outpatient care in particular. The counties, even though the counties don't have the level of control in New York that they do here, the counties were engaged in that process. The provider community was engaged in this process, and also the plan associations. So there was a lot of stakeholder engagement which went into this, and so it didn't kind of become the kind of food fight that I think could have broken out in some of these issues. Okay. New York State also, and this is kind of what I do, so I'm going to talk about this a little bit just to highlight it. New York State also invested significantly in providing technical assistance to the provider community, and I think it has been really important, and I like to say shaving the hard corners off, in providing ongoing guidance, one on a policy level, just letting providers know what is happening, when it's happening, what the dates are, what the rules are on an ongoing basis has been critically important to providers having a good sense of what's going to happen, when it's going to happen. And also in the background, one of the things that we've done really a lot in New York is we have a working group that does not include the state or the counties with all 18 managed care plans. And they're able to kind of come in and ask us questions that they don't feel comfortable when they have their public meeting with the state face on. And then we can take those questions and take them to the state without their names on them. And we've done a tremendous amount of work with them also on the billing requirements, just literally going through claim forms and being like, all right, in field 1, what is each plan doing and how is it different? Because United is a national company, so they have some requirement they have in Utah, so that's in their claim in New York. But it's different than all the other plans in New York. So how do you manage all those things so providers know very, very clearly exactly what they're doing and billing? And then the other piece, I'll just use a picture to illustrate this, is plans, is tools. So one of the things that I didn't appreciate when we went into this process is how many things for this transition that every single one of the providers in New York State was going to have to do themselves, or we could do it once. So there's 900 community-based mental health providers in New York State. Every single one of them for their own region was going to have to figure out how many plans were there, who the plans were, who they had to call for contracting, who they had to call for billing. When one of those people left, who were they supposed to call? Who do they call on claims issues? And all that could get replicated 900 times, or we could do it once. And so we built this matrix. It's online. It's not complicated, but basically you click on your region of the country. It tells you what region of the state. It tells you what plans are in there. You can click and then see all the different people you're supposed to call and all the resources you need. I would, as these kinds of transitions happen here, I would think about, are there similar tools that you can kind of implement that will help all of you, as opposed to having to do that 17 times or 500 times. I think it's really critically important. A couple real quick challenges. We had a waiver that had HCBS services as well. Those have been really slow to get off the ground, largely because to get into those services requires certain assessments which take hours to complete. And so folks don't want to do it. Providers don't get paid enough to do the assessment, and so then people don't do them. Obviously, there's an increased administrative workload. Consumer education, and I would also say, even being in the TA space, provider education. I can't tell you the number of times senior executives show up to meetings like this. We go through everything that's going to happen, but that information does not necessarily get disseminated beyond the C-suite back at the organization, right? And so the people who are on the ground actually having to deal with this, it becomes an issue. The billing issues have largely been resolved, and there's 18 plans, so some did a better job of it than others. And also the piece with providers was really critical. I'm going to skip ahead real quick. So I've talked about all this. I want to talk about lessons learned really quickly because I know I only have a minute left. So couple things just to highlight. One thing that came up over and over and over again was the issue of claims testing. So there's like a cascading series of things. So the state has to get out the rate codes. The plans have to log the rate codes into their system. Providers have to be contracted, and then they have to do claims testing. If all those things don't happen, all of a sudden on day one, people are filling out claims and sending in claims, and they bounce up against the system, and all of a sudden everybody's losing money. So the ability to set up those 4 processes well in advance so people have time to claim test prior to go live is really important. One of the things we discovered with a couple of the electronic health record vendors that were large vendors, they weren't small little mom and pop vendors, they were large vendors, that they weren't for certain programs set up to bill more than one MCO at the same time, and no one found that out till they tried to bill 10 at the same time. And then it all kicked back, or there was some glitch in your clearinghouse, or whatever it happened to be. So I would just really, really highlight the importance of claims testing. The other big thing to highlight is authorizations and language. So there was a thing that all existing clients got just carved in, and there were no requirements for the first 90 days. Providers took that to heart, but plans also needed to just know who the clients were and where they were receiving services. So they were asking providers to send them a list, and they were calling it an authorization. Providers said, well, there's no authorization. I went to this beautiful training, and they said there's no authorization for 90 days, and now you're asking me for an authorization. It was a language issue. And so I think as these things happen, the idea that everybody has to learn their own acronyms. We actually have a tool on our website which just lists all the acronyms. There's like 100 of them because substance use providers have a list, mental health providers have a list, plans have a list, hospitals have a list. And so learning everybody's acronyms actually became a really big issue. And then this other piece around billing, working between the providers, the plans, and what other entities are involved to really work on the day-to-day billing aspects and communicating as clearly as possible to providers not to wait. There was a provider that showed up, I believe in the state like a couple months ago and said something like, we haven't gotten paid in 3 years, and now we're not going to make payroll on Tuesday, and please help me. Well, how haven't you gotten paid? Well, we don't know. They just owe us a lot of money. And so the idea that providers and plans need to work collaboratively to sort these issues out in a timely fashion, I think has also been a real lesson learned. So I will leave it there, and we'll jump into questions.
Whew. I really did make the right choice, right? Though I'm sorry not to still be working with Andy. Obviously, he's got a great mastery of the complexity of these issues in New York, and I think the citizenry and residents generally are grateful for the work that he's doing there. Are there any super pressing questions right now? Oh my God, there are. Great. So I'm going to defer to the audience, and we'll insinuate questions when things get slow.
I actually have 2. And one goes to Mr. Gaither's example of having a patient that came in medical and had secondary behavioral health issues. The medical got to a point where there wasn't the acute need and the payer walked away. And it's like, wait a minute, we were on a date a few moments ago and now I got dumped at the prom here with this going on. What to do with that and how to form a better relationship to get there. Second is wonderful presentations, and it is certainly hopeful to know that something like that can actually happen. We're in an environment now today where it is so separated that I don't know how we help get over that chasm. Your presentations are wonderful for seeing the other side, for showing a land that could be, so we can stand up on the hilltop and look down. But how do you get there? Especially when you have people or payers that may not want to go there, but have a significant accountability. So just those two questions.
Take us over the rainbow.
So I'll start with how you get there. I don't know if I have any answers. And I would ask Luke to jump in because he was involved in all those conversations. I think that how New York got there is they laid down a marker that things were going to change. And that they could change in a way that was collaborative and in a way that kind of made everybody slightly unhappy or made everybody really miserable. And then they engaged in a very collaborative stakeholder process where they put a bunch of people in a room and said, all right, how do we make this work in the way that, doesn't reduce patient care, that, improves out, really the triple aim, right? So that, improved outcomes, engage people in the process, and then just started making steps. And I think the idea that, not changing was not one of the choices available really forced that. And I think the other piece was the outcomes. I think to say, look, we spend twice as much money as any other state. It's not quite that, but we spend an obscene amount of money on these services, and our outcomes are way below the national average. I think had a big change. I think the other piece of it that helped with stakeholder engagement was the level of provider protections that were involved. I think had New York State gone forward with this process without the guaranteed rates, without the network requirements, without the medical loss ratio, I think there would have been substantial pushback from the provider community. And I think because of those issues, I don't think there was the level of pushback that, look, this is not an easy process and whatever, but I think because of those kind of provider protections put in place, I think there was less pushback than otherwise. And I think there was a lot of transparency. I mean, the state would come out and do presentations, and Luke would do a lot of these too, and just say, look, we don't know the answer to these 5 questions yet, but we're working on it, and we'll accept any input we have. So I think that's where I'd say.
Yeah, that's great. I would just add quickly to with respect to the New York experience, that one of the sort of tensions in the initial conversation was around sort of the sense that integrated care would be better, that we all sort of collectively, felt some degree of certainty about that. But then there was also just great fear about the amount of money that would sort of, get flowed away from patients whom we, all agreed would need a lot of resources. And so relatively early on, I think there was broad recognition that we weren't facing necessarily a sort of simple dichotomous choice, but that we could sort of think somewhat creatively about how to structure the carve-in so that it would be a bit more nuanced. And Andy mentioned the SNPs, the HARP. Disco would have been great, but the health and recovery plan was actually, it emerged out of this sense that we need to create a kind of structural protection that is, not just about sort of the protection of funds, but is also about the creation of more robust services. Now, the challenges in actually landing them are formidable, as Andy has mentioned, the HCBS services. But that was really critical, I think, in kind of massaging the politics forward and ameliorating people's really considerable fears about resource loss.
I would add that in Tennessee, the governor said we're going to do it. So it could either be a little bit painful or a lot painful. So from what I understand New York did, though, they took a better path than us around laying out that there would be some protections on funding levels and things like that. We were more of a, in our state, the MCOs just negotiate rates with their providers. So understandably, providers are a little worried about that. So I think you guys had a better approach than we did on that. But you start out the same is this is going to happen, and it's got to happen, and this is why it's got to happen, and just took a leadership step to go forward with it.
So I can't add too much on the first thing, although I think the way, Andrew, you described the way New York went about it was very similar to the way that Access in Arizona went about it. And some of those protections and a lot of focus on claims and a lot of monitoring and a lot of that went into place well in advance to get people to the point of comfort where not everyone was going to be completely happy, but I think everyone saw that it was going to be a net benefit. And it was certainly going to be a net benefit for the patients and the members that we were all trying to serve. But I think you described it exceptionally well. But you asked another question and about the experience you had with the difference in the two payers. So first of all, I hate hearing stories like that as a CMO at a plan. Even before we had integration, one thing I'd say is that the culture, I think, in Arizona, even amongst competing health plans, of which there are several, is quite good. We pick up the phone and we talk to each other as the CMOs, and we resolve these issues. And these payment issues largely are resolved real time between us, and we fix these things. And I think that says a lot about the way that the culture of the system should work. And I also think it says a lot about the relationships we try to have with the hospitals and the partners that we have, because we don't want them stuck in the middle. We realize they're trying to provide the best care possible and that these things sometimes just get dicey, and we just need to step in and resolve it and fix it. Now, I think the integration is going to help that leaps and bounds. Basically, I'll have to have fewer conversations, otherwise I'll be talking to myself about, which side of our business will take care of it. But so I think that's a benefit of integration, but I don't think that we weren't resolving or weren't trying to resolve those things beforehand. One more example is the collaboration with the state. So with this transition, interestingly in Arizona, the behavioral health beds are still paid on a per diem basis, where all the medical ones are on a DRG. Well, we know there's going to be people admitted to medical facilities, if you will, physical health, that have a primary behavioral health diagnosis. So how do we resolve that? Because the DRGs are not going to compensate the same way that the per diems are. That's just not the way they're set up. So it was immediately identified. We came together with the state. We've created a process in a matter of weeks to fix that. We're working now on the development of how the claim system is going to adjust and operate for that. But we're going to just do it because that's what has to be done. And that's what will get the facilities out of the middle and compensate them properly for the care they're providing.
My question came about during the Arizona presentation, but it may be applicable to the other states as well. You said that, I believe, that in Arizona you have integrated plans for adults with serious mental illness. What happens to them when they are no longer seriously mentally ill? Do they have to go to another different integrated plan, or do they stay with their providers otherwise? And what are you doing, if that's true, if that happens, to prevent this ping pong effect between SMI and then maybe now I'm on meds, I'm fine, and back and forth?
That's a great question. So the way it happens right now, at least in Arizona, if someone either chooses or becomes decertified, then they would need to pick one of those integrated contractors, leave the REBA integrated care, and go to one of the integrated contractors. It goes back to there is a defined transition process whereby we exchange on a daily basis all that information with each other so that we can take over and assume care in a responsible fashion. Similarly, we take care of a lot of individuals that would be just classified as general mental health substance abuse individuals who are really, really an SMI designated type individual, who may or may not undergo or be willing to go through an assessment and be deemed, and then they would have to pick the REBA plan. There's a little bit of an exception. Because there is just one REBA in each of the three service categories or areas in Arizona, a member still has to have choice. So they can choose to opt out of the REBA for their physical health services and receive those from one of the integrated contractors that services the areas, but they do still have to receive their behavioral health services from that regional behavioral health authority. So a couple little caveats, but that's the way that we do it. And I think that the main thing is that are the handoffs. Really a defined process for clear handoffs so that people don't get hurt in those transitions.
I would just say in Tennessee, we have just 3 statewide MCOs. So what your designation of SMI really doesn't matter. In the old model with BHOs, an SMI designation would trigger a different type of payment to our BHO. And we found that a lot of time was spent making sure those assessments were done and up to date. So we wanted to get away from that. Not to pick on Arizona, there's different models to do everything, but I think just you stay in that plan's responsible for you no matter what your diagnosis is. That's our preference in Tennessee.
And in New York, the HARPs, are the special needs plans for adults with serious mental illness and substance use disorders. Those plans are plans within a plan. So the United, just to use United as an example, they have a HARP plan that's part of their general plan. So if somebody is no longer eligible for the HARP, they would just likely stay in the United plan. The only caveat to that is consumer choice. So people can opt out of the HARP plan, they can opt into the HARP plan, if they meet the eligibility requirements, and they can also opt to go to a different plan entirely. But they can stay within the context of that larger plan. So the disruption shouldn't be that much.
And one more key point, sorry, all these state nuances. So these REBA contracts that I described in Arizona, they will term in a few more years. And so nothing's been declared yet, but there's some assumptions that perhaps those will be retired, if you will. Those plans are all also integrated contractors in the service areas. The state designed it that way. So I think if they decided to just integrate the rest of the adult SMI system, they can do it pretty seamlessly. They could just not renew and not rebid those REBA plans. And that's my sense, but we'll see.
My question is for actually an issue that was brought up by Dr. Kleek. So on the challenges slide, you had mentioned public education or awareness of how to consume healthcare in the system as a challenge. And whether or not you're in a carve-in or a carve-out state, that is a major issue. And I was just wondering, did you guys engage in any kind of comprehensive public education campaign or anything like that to try and address that, or is it an ongoing challenge?
So I'd like to talk about that in 2 different ways. I think one is consumer education for the folks who are, patients who are using the system. I think that's happened in 2 ways. I won't say it's been a great job of doing it. One is providers have done a lot of education around providing the members that they serve, as in the plans have done a lot of that as well. And then the state put out, on a kind of a separate silo, put out actually a pot of money to one of the peer-run organizations in New York State to actually provide consumer education more broadly about the carve-in. And that was direct to consumer education. And a lot of counties and localities did a bunch of that as well. I know when Luke worked at the city, I think we did one of those together for consumers in New York City. I think it's an ongoing challenge. I also think, just to reiterate in there, the frontline provider piece is also really an issue because you can't free up those staff to go to trainings all day long. And so for providers to be able to give those concrete tools, not only their frontline staff, but then the education of their frontline staff so they can explain all of this to the consumers that they work with, is also a really important piece. I would not say that we've done a fantastic job of that in New York, but it's a bit of an ongoing challenge and something that I think will continue to get better over time.
I have a 2-part question. One is, for each of the 3 states up there, do you think that the state Medicaid programs are kind of leading the way and commercial insurance is kind of following behind as far as carving back in? And then I'm also curious if you have the numbers on what the total Medicaid spending is per member per month in each state when you combine both the mental health and the physical health care, and how that would compare to California.
Oh, I think the first one's kind of easy, at least for me. I think that, I think a lot of the Medicaid state agencies are leading the way, and I think that that's also true in some of the innovations. Now, granted, they have the we have the pleasure of getting funding to support some of these things, whether it's district or in Arizona, there's something called targeted investment, which invested $300 million into trying to further integrate physical and behavioral health care, and I'm sure there's multiple more examples. So we get to be a little bit of a petri dish, and we get to experiment a little more with things, and I think that helps to accelerate the change, and that's exciting part of what we do. I don't have on the second point, I don't have the PMPMs. I know it varies by rate code though, and there's a lot of rate codes as well. So, and finally, in Arizona, since the largest integration that I described happened on 6 weeks ago, is still new. Yes, we've got rate books from the state, but we won't know what our real experience is for a year or two now.
I don't know our PMPMs off the top of my head, but I assume California's higher. Just because everything costs more out here in California versus Tennessee. What was the other question? Oh, state lead the way. Yes, I think part of that has to do with, I view us as a purchaser of insurance, which is what Tennessee considers ourselves. We're just like an employer, and so it's up to the employer what packages they want to buy, and until that commercial market, they can offer lots of products. It's the employer's got to decide if they can afford that and what they want to do with it. So healthcare is always different than everything else for some reason, but it depends on who's purchasing and what they want to buy.
So I would agree that Medicaid in New York is certainly leading the way in terms of innovation, and I have had a lot of conversations with people who have, children who have significant mental health or substance use needs, and what they can get access to in Medicaid versus what they could get access to on the commercial side is it's drastically different. I also do not know off the top of my head the PMPM. I would take a guess, but I'd probably be way off. I know the HARP number is like 2 to 3 times the regular PMPM, but I don't know the number. And then to combine those two is what you really need, and I'm not sure.
Good morning. My name is Sharilo. I'm the Vice President for Behavioral Health for the Hospital Association here in California. Thank you very much for going through the painful process that your states have gone through. I'm hoping that our state gets to go through a less painful process, but that they do something in the future to improve our very fragmented system of care. One of the most common objections that I hear about merging physical health and behavioral health is that the community delivery system is all about recovery and that they don't want to medicalize behavioral health. I'm curious if you encountered the same kind of objections and how you overcame them.
I just want to editorialize that that's a really great question.
So I'm glad to talk about that a little bit. I will also editorialize and say it's a great question as well. I think there has been a pretty deep stakeholder engagement process in New York New York did this through a Medicaid redesign team. So I talked about this kind of intensive stakeholder process. One of the members of that team runs kind of the statewide peer advocacy group, and has had a big impact on the way that things got done in the engagement. And I think recovery is critical, but I think one of the things that and this is not completely across the board, but that peer-operated agencies and recovery-based agencies have said is without having access to also improving the physical health of the consumers that we work with, we're not really in the recovery business. So the need to do both of those things simultaneously, I think, was important. I would also say that within the context of that movement, there's still ongoing disagreement about, and that the issue of over-medicalizing is an ongoing and not going away kind of issue. But the idea that people were being treated in a silo and they didn't have access to the physical healthcare needs was important. And I think the other piece that was also important was our commissioner at the time was Mike Hogan, who did the national, the national, and now I can't remember the name of it, but the national paper on behavioral health, and identified that people with serious mental illness die on average 25 years earlier in the general population, and so that kind of really highlighted the need for this kind of integration.
I think it can lead to a more medicalized model. The flip side of that is I think it brings up questions around what does recovery look like and what are we getting for the money we're spending, and So we obviously don't want it to be a medicalized treatment model, but it does invite a new conversation, which can be uncomfortable for people. But what are we getting as a long term? And that's kind of also why we went with this HealthLink model, is that you're still in recovery, but how about you help us engage that member in those medical issues in their life, so that we're getting the most bang for our buck on that. So I think there's different ways to approach it, but it's a legitimate concern that has to be managed very well.
So I agree with what everybody said, and I'll add that, I think the stepwise approach that occurred in Arizona, I think that helped because people eased into it. There was different populations that slowly got eased, and the systems came together kind of over a 5-year period until this recent big wave occurred. So I think that it gave providers on both sides, physical and behavioral, an opportunity to learn and experience what was going to happen and see that it wasn't being perceived as the system's broken per se, and that it was all going to be medicalized as opposed to a focus on recovery and resiliency and other models. And there are actually adult and child principles that guide the behavioral health delivery system in Arizona that actually born somewhat from some lawsuits in the past, and perhaps that helps as well. So I think that because of the time frame in which we integrated and the way in which it was done and led, I think that contributed a lot. And then from the United Healthcare perspective, since we are a United Health Group with Optum Behavioral Health and United Healthcare, Optum Behavioral Health operates in a lot of different states, providing a lot of different behavioral health models and with different partners across the country. So I think to that end, at least in our company, it's not medicalized. There's a very distinct focus on behavioral health and behavioral health principles that is really closely interwoven, I should say, with our medical and physical health philosophies. So I think that helps us, as at least organizationally within United Healthcare.
I think it's incumbent on the states to try to remove that fear, provide some assurances to the providers, because it absolutely would be a worry if I was a provider out there. So it sounds like we did that to some extent, but New York went further than we did on trying to allay those fears. Because if everybody's too afraid of this, it's not going to happen. So you've got to have some type of assurances out there.
Yeah, and one thing I did mention was probably the biggest thing, which was part of the federal waiver, was actually funding peer services in a much more expanded way than they had been funded previously. So that was one of the major pieces of the federal waiver. So I think that allayed some fears as well.
So I had one question, but now listening to you all talk, I now have two. First question is, one of the areas of pain points that we see, it comes to discharge planning, whether between our counties and our MCOs and with our hospitals. And obviously the hospitals have, as their condition our participation, they have to do a certain amount of discharge planning, but then there's also the push to try to get those placements in network. And so there's been a difficulty balancing those two obligations. I'd love to hear how you guys have addressed that, or if it really hasn't been an issue because of the network adequacy requirements. And then the second question is, in your states, how do you fund your IMD services?
So I'll take part of that. So I think the discharge, so the network issue isn't as big an issue in New York because they kind of mandated that the entire network was part of everybody's network. So that hasn't been an issue as much yet. It will be as we move towards value-based payment, which is a whole other conversation. The discharge planning piece is an ongoing issue, I would say, in New York, in that the hospital systems, community-based systems still don't interact in the way that we would all want them to. I'm sure that's a common national problem, not just a New York problem. So that's an ongoing issue. The IMD stuff is still paid fee for service by the state. It doesn't go through the plans at this point.
So for us in discharge planning, I think we work to discharge plan from day one, again, with the hospitals. So I think that the benefit of having the integration now is that we'll be far more aware of, I think, the person's arrival in the hospital. We don't always get notifications, but we have electronic exchange with all the hospitals. That helps give us a heads up that someone's there. And I think that you mentioned network adequacy requirements. We usually well exceed the network adequacy requirements. So I think that we've got a fairly robust network. Payment, I think, is commensurate with what the expectations are for those providers to receive. So I don't think that we're having a difficulty building the network and growing it. So I think that also helps us too with the way the rates are set in Arizona. And then on the IMD piece, the way it was until recently was actually a bit more liberal in Arizona. We underneath the 1115 waiver, we were able to pay for more than 15 days and go beyond that. It was covered underneath this in lieu of. So we were going to pay for this in lieu of a more expensive or an equally expensive service someplace else. But with the changes recently, that's no longer the case. We're now limited to 15 days, and after that, the state just drops our cap for that individual for the month, but we still pay for it. So if the member's still there, we can't help to organize or set up a transfer or lower level of care, then that's on us to keep paying for it. And the last piece of that, and I mentioned it, is that there are a number of non-IMD facilities in Arizona, and those have, I think, grown over time, and that goes back to some of the development work that was done well before this integration when that was an issue. So I think having a number of facilities that can help meet those step-down needs and always looking to grow that network has been very helpful.
We were an in lieu of state as well, so that. I will say, as far as the 15 days go, most of our admissions are 15 days or less. So you're talking about there's a group that unfortunately stay for an extended period of time, and we're still working out ways to pay for that. It's going to be paid with state dollars. But up until recently, it was all the responsibility of the MCOs. And we would just use the in lieu of provision to help pay for that. It doesn't make sense to move them to a cheaper hospital that's not an IMD.
Any other questions from the audience right now? I think we still have a little bit more time.
Yep, about 10 minutes.
Okay, cool. Are we certain there are no other questions right now? Then I'm going to ask a couple. I would love to hear you guys talk a little bit more about the particular challenges that you faced weaving together changes in the substance use disorder service delivery system and the mental health disorder or mental health service delivery system. Those are, so not only is behavioral health segregated from mainstream healthcare, but those are two very, distinct specialty care systems, both of which relate to hospitals in somewhat different ways, both of which have different relationships to the notion of recovery and different, sort of resistances to medicalization and different opportunities to medicalize in different ways. So I'd love to hear you sort of talk about what some of the challenges were in addressing both substance use disorder and mental health at the same time and how you address them. Thanks.
So you notice that we all took a deep breath when you said that. New York is siloed in a whole bunch of fun and exciting ways. And one of the ways that it's siloed is at the state level, there's still a Department of Health, a Department of Mental Health, and what we call OASAS, which is the Department of Substance Use Services. So funding is siloed. You have separate licenses for mental health and substance use services. So there's that complexity, and that continues even under all of these changes. The Office of Mental Health and OASAS in New York have worked closely together on this transition. There's still some things there. The substance use service field has taken the opportunity of this transition to actually kind of rejuvenate the clinical services, transform the clinical services offered in substance use. But I think one of the things we talk a lot about is the need to really go back and do some integration on mental health and substance use. The CCBHCs, which is one of the new federal mechanisms, has started to push that a lot, of integrating mental health and substance use. It is still a pretty bifurcated system in New York, and I think that's an area that needs a lot of work. There is work in that area, but just to Luke's point, the language issues alone, are, when you say recovery or peer in those two different rooms, you get very different, very strongly held views on what those two words mean. And coming together around that, I think, is really critically important.
A few issues that came up. Billing fee for service was a struggle. And from a language perspective, authorizations and concurrent review were very foreign to a substance use provider, and they've got a 28-day program. And in the managed care world, you may want to know what's going on after 2 weeks, and how does that look? So that's been a struggle, but I think they're getting used to it. And the discharge planning is a benefit of integration. It's connecting those other services. And a related issue to that is, and everybody's dealing with the opioid crisis. most of our substance abuse treatment system, or at least what was in Medicaid, was abstinence-based until about 2 years ago. So we've got a big push going out to get more MAT providers, buprenorphine, but make sure it's a good model, which has a mental health component to it. So having an integrated payer facilitates that conversation with a PCP's office that can partner with some counseling in another area to try to expand that access. We're woefully under-accessed on MAT services, but having that integrated model facilitates that process for us.
That was a good question. I'm glad I'm going last. But it gave me a chance to think about a few things that are a little bit in addition to. So the state, again, I think led a little bit in this, that even before the integration occurred, they started allowing physical health providers, PCPs, who were waivered to do MAT services, and that was even before there was integration. And they said, doesn't matter that the benefit was sitting or is sitting with the REBAs until 10 months from now. This is an urgency, so we need to speed it up. So again, I think the state took leadership. We were able to quickly accommodate that and add and expand MAT provision services in primary care settings. The other thing the state has done, which we're supportive of, is developing centers of excellence around substance abuse treatment in Maricopa and Pima counties, the two larger counties. And those are largely in integrated physical behavioral settings where all the right services can be provided, I think, in the right way. And again, with a focus on trying to assess outcomes and assess what's coming from that experience so that we know they're on the right track versus the wrong track. And then from an internal United Healthcare perspective, one thing I'll say is that the leadership we've had over the last 3 years or so, 2-3 years, has really taken the stance that we need to infuse and develop the training of our own care management staff far above and beyond where it had been. And yes, that was in part in preparation for integrated care as that was coming across the country, but also just because without having people that are trained in motivational interviewing and who don't know how to meet someone in the field and develop trust because they don't have their laptop open in front of them. I mean, lots of different just characteristics of interfacing with our members in a more meaningful way to try to help impact them. I think that's also something that the health plan, at least our health plan, has been really endeavoring to do, to be different and help encourage people to accept help in ways differently and not to give up. Just because it wasn't today doesn't mean it won't be, 2 weeks from now. It doesn't mean it won't be a month, won't be in a month.
Thank you so much for those excellent answers to what I agree was a really excellent question. I think we are actually right up against our time limit here. So I want to give a really heartfelt thanks and expression of gratitude to our three guests from across the country, Dr. Andrew Kleek, Keith Gaither, and Steve Charnokian.